points. I still haven't. Here we go. Disable waiting room. All right. Um, Ravi, this is a case that you saw in a patient you saw in the Baltimore area.
Yeah, as one of my residents saw. So I thought it was a good case to sort of shoehorn in for one of the VMRs. So I hope you enjoy it.
I'm sure we will. And we can maybe go ahead and get started, and we'll catch Steph up once she joins. Does that sound okay?
I think she just joined. All right. So I'll start with the first aliquot. So today's case is about a 60-year-old female who presented to the emergency department. She had a 1 week history of constipation, and she described it as she was passing small pebble-like stools for this past week. And I'll stop there.
Um, what a nice place to stop, especially as the bowel seems to have almost stopped themselves. So what the patient is describing is um, Bristol. I forget which way the scale goes. The Bristol stool scale from 1 to 7. I think 1 is harder and 7 is looser, but Bristol scale 1, I believe, is exactly what's being described, kind of small, hard, lumpy pebbles. And then 7 is kind of frank, watery diarrhea, and there's a scale in between. Constipation is a maybe, I don't know, I would guess in the top 3 symptoms that humans experience that can be bothersome about their health and kind of bodily functions. Um, and most commonly, the causes are benign, um, having to do with inadequate sort of fiber in the diet, inadequate hydration, inadequate motility. Um, but it's one of those symptoms where it's extremely common, and the most common causes are kind of benign and mundane and not worrisome. But it can also be caused by very sinister things, everything from an obstructing colon cancer to a neurologic disorder. Bowel function is a neurologic function, and lesions in the peripheral nerves, as well as in the spinal cord, can impair that function. So I think when you deal with a symptom that is very common and usually benign, but has serious causes, kind of a classic analogy is low back pain as well, right? One of the helpful frameworks is kind of a red flags framework, and to see if there's anything about the syndrome, the case, that would make you think that this isn't just a routine, the most common kind of benign cause. So to me, the red flags for a patient we're coming in with constipation as a chief complaint would probably be more than anything just acuity. Most people this age who suffer from constipation have kind of dealt with it for years, if not decades. But if this is very unusual for them, that would be a red flag. And then just accompanying symptoms, whether there is uh, anything else, whether um, having to do with the character of the stools, with bowel habits, with pain, or neurologic symptoms, or pain elsewhere, or just some other systemic signal like fever, like weight loss, like malaise that has kind of preceded the onset of the constipation or something to that effect, that would also kind of make your eyes perk up. So as with anything, the world of possibility is so broad and infinite that I find it always helpful to just be open to any possibility and anchor the evolving diagnosis in more of a chronologic story. So I would love to ask this patient and Ravi Tell me more about this constipation, and here sort of a beginning, middle, and end, along with any other details and things that have been that come to mind as different recently.
Absolutely, absolutely wonderful start to the discussion. So a little bit more story. She obviously described these small pebble-like stools, and there was mucus. She did go seek some over-the-counter remedies such as enemas, suppositories, magnesium citrate, prune juice, but none of these alleviated these presenting complaints. She didn't have any nausea, no fever, no chills, no hematochezia, no melena, no previous history of any bowel disease. She had a colonoscopy about 5 years prior, which was unremarkable. And a little bit more background. So she has a history of hyperlipidemia, and she also had a history of vaginal squamous cell carcinoma, including laparoscopic assisted vaginal hysterectomy in 1995, radical vaginectomy in 2018, and then subsequent teletherapy and brachytherapy, and since then has been asymptomatic. Medications, just meds for constipations that were described, nothing else. No previous family history of any colon cancer, no health related behaviors, no social history, no, wait for them to catch up, no allergies. And I'll just jump to the physical exam. So, vital signs, temperature, afebrile, heart rate 87, blood pressure 134/80, pulse ox 99% of room air. Generally not in any distress, looking quite comfortable there. All the exam was pretty much normal except like the abdomen, it was soft. There was slight tenderness over the lower quadrants. No rebound, no distension, no guarding, and no surface abnormalities, no asymmetry, no scars, extremities. There was no edema, and I'll stop there for discussion.
Steph, I think you came in before the second aliquot, right?
Yes, but if you want to give me kind of softball me a problem representation, I can kind of hop on the train.
Um, yeah, you didn't miss anything but the chief complaint and kind of a general um, thoughts I shared about constipation in general. But it sounds like you know, a middle-aged woman, previously healthy except for this very remote history of surgical and radiation treatment for vaginal squamous cell cancer, who comes in with kind of isolated constipation for a week, and with not much other relevant findings on history or exam, save for some tenderness in the left lower quadrant, in both lower quadrants. One thing I might have missed though, Ravi, is like again just the time course. Like before a week ago, she never struggled with constipation, and this is sort of a new and surprising symptom for her.
So she's always had some element of constipation, not to this degree. So she would have maybe several, like a lot of our population may have several bowel movements per week, have to take medications to augment the bowel movement. But now she was having small pebble-like hard stools. So this was a marked change from a usual pattern.
Mm.
I'll guess.
Samantha had some questions too. Sorry, Steph, to interrupt.
Yeah, Samantha, just I'll sort of layer on. I heard Zavin's discussion of the constipation, but yeah, very broadly, um, thinking about kind of mechanical issues of obstruction, issues with motility, and then just the content of the stool itself. So Samantha, I had the same thought about dietary changes for any patient. For example, right, sudden cessation of coffee intake. If someone might be very used to that, and that might be very critical. So really just asking this question of has what has changed in the diet. thinking about, again, those categories, obstruction, motility, and then actual stool content. I think here the history of having had pelvic surgery and radiation really kind of makes us worry potentially more about anatomic obstruction. And knowing that she has a baseline history of constipation, I think is really important context also. It's interesting, radiation can cause both sides of the spectrum. It can cause radiation colitis, both acutely after you have it, but then even over time, people can continue to have sort of bowel irritability from the prior injury, but then just effect on motility leading to more of a constipation side of the spectrum is possible as well. So helpful to know that she was more on the constipating side in general. I think the exam is really helpful. Additional exam maneuvers to think about would be if she's, comfortable accepting actually a digital rectal exam, because one question is some of the issue here that there's been gradual constipation with actual impaction, and there's actually just a very, very hard kind of obstruction by the stool itself there that could be kind of manually or mechanically removed at all. And so, we don't think of kind of doing a rectal exam on a lot of patients as part of the general, but could actually be useful on this particular host. Other things you want to layer on, Zavin, given the additional history?
Not much. I'm wondering what these constipation meds are. I think being in the situation she's found herself, if she's only taking the largely ineffective docusate, would be different than if she's found herself in this situation despite taking senna and polyethylene glycol and magnesium citrate and lactulose. So I don't know if you have that information, Ravi, but just to sort of judge the severity of the process. And then Steph, I don't know if you were thinking of this too with the diet, but you mentioned withdrawal of caffeine or withdrawal of other habits that keep your bowels moving. But you probably remember the time years ago where um, I bought a big case of persimmons and and we learned about a week later that persimmons are extremely constipating. Just the sort of the same astringency, I guess, that you can feel in your mouth when you eat um, a persimmon that isn't quite ripe yet. Have been described to have, I guess some of those substances have a very constipating effect as well. So I think both what have you stopped eating, but what have you perhaps started consuming in the last couple of weeks could be interesting to hear.
All right, awesome. A great point, Stephanie, about the rectal exam. When I was listening to this case, I said the same exact thing. So it's interesting that we're sharing this similar train of thought in regards to this patient. So Zavin's shedding some light on medication. So she would just take the garden variety over-the-counter stuff, but now needed a lot more like a next level stuff, Miralax and so on for these pebble-like stools. She did visit a clinic and they did prescribe her that, and it didn't alleviate none of the over-the-counter things or the prescription-related medications alleviated this. So that's why she came to the emergency room.
I guess, Ravi, if I could ask one more thing about the exam, I would also just be curious in a patient like this, both on history and exam, to see if there's other signs of neuropathy, if there's any numbness, tingling, kind of loss of distal sensation, just to see if this may be a part of a systemic process. But I'm perhaps by omission, the answer is no.
That's correct. Yeah. Okay, so let me move on to the labs. So the labs really didn't show anything major. The white count was 10, hemoglobin 10.9, MCV was normal, platelet count 200, and chemistry was normal. Urine analysis was normal. And I'll just stop there for a little bit if there's anything you have in mind before we move on to the next aliquot.
Um, I don't think they point us kind of in any particular direction. I'll shout out what Andrew said in the chat about a true inflammatory complication you can have from long-term constipation, particularly when it leads to impaction, is stercorocolitis, which is when, right, a big sort of usually hard mass of stool actually causes distension and stretch of the bowel wall, such that it actually gets kind of relative ischemia and can actually get necrotic, can lead to perforations. And it's radiographic really in how you diagnose this. The patient has pain, but not necessarily sort of inflammatory symptoms. But when you do a CT scan, you'll see a thickened mural wall, you'll see stranding, and you'll see that what's actually distending the colon itself is a big stool ball. So stercorocolitis is an inflammatory complication of constipation. I just mentioned that, seeing, her white count is at the upper limit of normal, right? Where is that compared to usual? And is there a relative leukocytosis there? And then I don't make too much of you mentioned normocytic anemia in the context of some of her medical therapy. But if we find out later that she's iron deficient, putting that picture in with this worsening constipation and what kind of GI chronic blood loss etiologies could be leading to both constipation and iron deficiency are just two thoughts I had looking at the labs.
Yeah, Steph, the anemia makes it on my problem list too. The MCV is only partly reassuring. Certainly, if it was low, the iron deficiency would sort of skyrocket to the top. But you can have mixed kind of contributors, a macrocytic concurrent process that kind of averages out the MCV as normal. So I would still want to know the iron stores. And the other thing is just on the total white count, curious about the differential. Um, I've seen many cases now of kind of even mild inappropriate eosinophilia being a clue to sort of potentially have a higher pretest probability of even solid malignancies, including rectal cancer, actually, in one case. So always want to know if there's any kind of signal of inappropriate immune stimulation.
All right, so I did have the same questions about iron deficiency and possibility of malignancy. So the iron studies were normal, and there wasn't a differential that I don't remember a differential, but there was no fever, and the white count was around 10. So the next, any comment before I move on to the next aliquot? Okay, so the next aliquot, I'll show you imaging, and I'll just share screen. So there's a lot of red arrows there, but I'll let you take a look at it before I comment on the radiology read.
Are you able to make it just a tad bigger for us, Ravi?
Sure.
It's very helpful to have um, the kind of mid-sagittal panel A, where we see the vertebral bodies, lumbar spine, going down to the sacral and to the coccyx. You see the spinous processes. Anterior or to the left of the vertebral bodies is the descending aorta, and then it stops being visible when it bifurcates and is no longer a mid-sagittal structure. We see the tip of the liver at the top of the screen, the left hepatic lobe, as well as probably a cross section of the transverse colon right below it. And then we see uh, some small and large intestine lower down. So everything up there looks more or less normal. There's not a lot of gaseous or liquid-filled distension of the small or large bowel, importantly. And then in the pelvis, the red arrows, both in sagittal and transverse cut, um, are showing. So that is around the rectum, but adjacent to the rectal lumen is an eccentric, somewhat contrast-enhancing mass with a relatively hypodense center. And again, it sort of seems like it's either right next to the wall of the rectum or part of the wall of the rectum. I think the differential here is potentially infectious or malignant, with the potential malignancy looking this way just because of central necrosis. But yeah, definitely an abnormal kind of mass lesion structure that is adjacent to slash within the rectum and certainly kind of creating a mass effect on the lumen of the rectosigmoid kind of large intestine. And actually, even just sort of beyond the what's pointed out by the red arrows, if you look a little bit more lower down on um, the sagittal image, you see that the rectal wall in general, unless that is just sort of like thickened, fibrosed, chronically present um, tissue related to her past malignancy and treatment, it's more than just what's pointed out by the arrows that is abnormal. It looks like there's actually kind of circumferential thickening of the rectal wall, rectosigmoid wall, diffusely, even outside of that kind of contrast enhancing round centrally hypodense lesion. Um, so I would definitely kind of want to very closely read, if not discuss with radiology exactly what's going on, but a lot of abnormalities that more than explain her presenting symptom, in my opinion, to where I would just reframe this like away from this is no longer constipation. This is kind of rectal thickening and a perirectal mass without yet kind of overt sort of obstruction, without proximal bowel wall distension, but certainly explaining her kind of slow transit and abnormally hard bowel movements.
Can I just add two quick comments? That was artfully done. As far as I know, Zaven did not do a radiology residency, but there you go. You can see, the word rectum, right? Like from the word root, like rect or recto, right? Meaning straight. Look how straight down that part of the colon is. I just think that sagittal view is just a great example of the rectum being like the final straight passageway out of the intestines. And then curious what the group thinks, particularly in the sagittal image. The looks like she has a lot less visceral fat than most people. I don't know if others agree with that. She's got some subcutaneous tissue, but just in terms of like how much little mass there is between the plane of her abdominal wall and then her kind of spine, I'm just struck by that. And anyway, wonder if that makes her sort of predisposed to either kind of obstruction or dysmotility issues, if the usual cushioning that's in there between the organs isn't there. But I don't know
Mm.
how they read it, Ravi. You can tell us.
Absolutely spot on. Great observation there, Stephanie. The reading actually came back as interesting. There is around those red markers there that Zavin had described about a 2.7 times 2.6, and they described it as a mural abscess. A lot of constipation, so significant stool burden, but they thought this was abscess. And like Zavida mentioned, that thickened sort of fibrous could be inflammation that's sort of emanating distally from there. And that likely was causing these hard or obstructing the stool passage, causing these hard stools. Any comment on that?
You said so they really called it a abscess in the wall, and they did that based on the sort of rim enhancement that was there. Interesting. So I think the question is like, how do you, get an abscess in your kind of colonic wall, right? Certainly there's bacteria coursing by all the time, but really suggests that there was sort of a luminal, right, defect that allowed inflammation and such to develop in the wall itself.
All right. And then moving on. So, due to this finding, broad spectrum antibiotics, Zosyn, Pip/Tazo was started. Gastroenterology was involved, and they recommended a colonoscopy to look in this area. And the next picture will be this portion of the colonoscopy showing an 8 millimeter ulcer in the rectosigmoid colon. And I'll stop there if any thoughts come to mind.
So would love the hear what the group thinks just in terms of approach to like colonic ulcers. Some overlap of what can happen with more upper GI ulcers, but some different pathology. Certainly, can still have ischemic injury, you can still have kind of inflammatory injury, right? Like with inflammatory bowel disease. Um, and medications can do it too. The same way NSAIDs can cause upper GI ulcers and the stomach duodenum actually can cause rectal ulcers as well. We don't have an NSAID history here, but some medication kind of induce sort of pathology is possible, right? Even without direct contact with that medication with there also. And then we've had the history of radiation also. Fairly not recently at all, but is this sort of sequela of kind of chronic inflammation that was induced by that therapeutic intervention? So I think that's how I think about it still. Ischemic and inflammatory medication or just sort of toxin related specifically and effect of radiation itself. And curious if others have thoughts on that. Oh,
I
thank you,
think that,
Avery, pointing out just in specifically with infection, getting a sexual history, right? Just sort of figuring out what sexual practices, et cetera, and some of the diagnostics that we can do for STIs elsewhere, right? Certainly can be do with a rectal swab as well. Sorry, Zavin, didn't mean to cut you off.
no, that's um, great addition. Detail from Anne Marie was also just gonna say that like I think the context is everything here. You know, if we round out kind of the some of the information we want, like the sexual history, and just realize that you know, she's not just any patient, but she's a very small subset of all people in the world who have received the pelvic irradiation, right? Then the pie of um, kind of causes of proctitis shift in her, I think, dramatically, sort of to be related to that history, which, you know, radiation proctitis can happen kind of years after exposure. Although I don't know if I've ever seen or heard of a case of, you said, Ravi, this was like 20 something years ago that she had the treatment for the vaginal cancer. But um, anyway, I think the context is just so important because if you just take the epidemiology of a certain syndrome in all people, right? Um, just the risk factors and the history of predisposing effects to each of those slices of the pie is such a determinant of in this person what is most likely. So not having kind of um, uh, known ischemic risk factors in the way of atherosclerotic vascular disease, right? Um, not necessarily having the social risk factors that we kind of know of yet, not having the medication exposures, and then not having other features of inflammatory disease, autoimmunity, IBD signs and symptoms. I think the one thing she has that makes her very unique is this radiation history. So um, that's kind of what I think in terms of the probability within the possibilities.
All right. I have two more images before I reveal the final diagnosis. So uh, the next step was endoscopic ultrasound, and you can see the crosshairs showing this 24 by 60 millimeter left posterolateral rectal wall non-circumferential lesion in the submucosal layer. And it was at this time then a biopsy was done, which will reveal the diagnosis. And concurrently, an MRI was done to look at this as well. And it showed the left-sided perirectal mass, but there was also a separate lesion along the right pelvic side wall. So this shed light on another. So you have the yellow and the red. There are actually two lesions that were seen. And then in the next aliquot, I'll reveal the diagnosis.
Avi, my Zoom kicked me off when you were actually reading the CT scan report. Um, So it was read as kind of a rectal wall mural abscess, stool burden. I see sort of the notes, but was there a comment on just like how circumferentially just the thickening of the rectum was present or not, and how like up and down kind of longitudinally, how much whether there was abnormal mural wall thickening, or was it just this like mainly the discrete lesion?
Oh, sorry, I didn't know you were kicked off. Yeah, so you were spot on with the read. So there was that 2.7 by 2.6 abscess-like lesion, and then there was distally to it a little tail end of inflammation, which you had highlighted on as well. So that could be emanating from possible abscess.
Got it. Um, yeah, I think the two kind of leading differentials um, for me just along the waist are radiation proctitis and then possible kind of rectal mucosal malignancy. And I think both of those could be associated with multiple lesions, kind of multifocal presence. And by the way, just the entire differential probably of for proctitis that Steph in the chat kind of thought about and listed do not limit themselves to a single discrete ulcer or single discrete mass lesion. Um, so I think that seeing the second kind of focus on endoscopic ultrasound doesn't shift the differential too much for me. And yeah, it's going to be all about the biopsy. And Steph, I don't know if you have other thoughts or kind of curious what you think is most likely, but
Um, Yeah, I would also just thinking of the patient's kind of healthcare experiences before, right, would be worried most about kind of radiation related versus new kind of primary, sorry, specifically malignancy there. I think realistically, with the biopsy, given some of the infectious sort of differential we brought up, ideally we'll get a sample for both histopathology and micro, just to make sure we're not sort of missing an infectious proctitis for which there weren't kind of clear signs or symptoms there. But if I had to put my money on one, would be kind of worried about kind of sequelae of the radiation in particular for her. Um, but that would require kind of ruling out a lot of other findings sort of on the pathology itself.
Steph, I was also just kind of imagine like if this was a patient you or I were seeing you know, at Bentab, who, you know, was a young person with, you know, with HIV, like just how different, right, the differential diagnosis would be, and how the two things we most suspect now would be at the very bottom, right, of the list, and there would be a lot, kind of a expanded spotlight of possible infectious causes, you know, viral, mycobacterial, fungal, um, as well as bacterial. So again, just always struck by the importance of kind of patient characteristics, context, and risk factors.
All right. So the biopsy was done and it showed high-grade squamous intraepithelial neoplasia with positive P16 and Ki67 markers consistent with recurrent malignant process. And the findings collectively were judged to be recurrent vaginal squamous cell carcinoma with rectal wall invasion and possible metastatic spread. And then the patient followed up with general surgery and gynecology and is undergoing treatment. And in spite of over 20 years ago having the hysterectomy and also the vaginectomy, 20 plus years later having a reoccurrence with this pebble-like stools and constipation, which was very odd in this case. And looking at this, it reoccurrence of vaginal squamous cell carcinoma occurs like in probably a quarter of the population within 5 years. This was like beyond 5 years, which was just unfathomable. especially when thinking about this case. So it's very rare. And and usually, yeah, these vaginal malignancies invade adjacent structures. That's why it was in the rectum, I guess, and can resemble the differentials we talked about, infectious inflammatory conditions, and can also be very non-specific in its presentation. So, and that's the conclusion of the case. Any reflections, Zaven and Stephanie?
I think for me, just how remote the history of the original cancer was, I made it just not a consideration that was really at the top at all. And I guess presumably, yeah, I mean, with the kind of additional markers and things that they did, they knew the original source was the primary cancer, right? One could think about, right, other new malignancies, as we said. So it's just terrible, kind of terrible luck and tough outcome for this woman to have that 20-year delay with recurrence.
My my reflection is similar in that yeah, I like when I was talking about cancer, I was thinking of a new primary malignancy. I was not thinking of recurrence. Although now in retrospect, just connecting with some of the things I know about squamous cell, mucosal squamous cell cancer versus kind of rectal adenocarcinoma, it sort of makes sense just because usually like colon cancers, rectal cancers, I mean, they can be an ulcerated mass, but something about the endoscopic description of it was a little funny. Um, just rare to look that way. And then squamous cell cancers are more prone to sort of central like necrosis than adenocarcinoma. So given like just the size and how much central necrosis there appeared to be just on the imaging, um, yeah, I think there were clues along the way, but yeah, very unfortunate and just surprising that that something can stick around for so long, right? And be, I guess, kept at bay by immune surveillance and stuff, and then eventually kind of break through. And then the other just sort of thought I had and teaching point to keep in mind with some optimism is that, we talk about kind of HPV vaccination being an amazing intervention to prevent almost all cervical cancers, right? But HPV also causes a lot of vaginal and penile cancers and head and neck squamous cell carcinomas. So I think we can hope that with ongoing kind of use and uptake, a lot of these squamous cell carcinomas can be prevented in the future. Um,
Thanks for a great case, Ravi. Hans, do you want to give us some summary teaching points?
Yes, just a brief summary, and thank you very much for the great case. We started our case with a brief reflection about constipation, and there I think our first concern was to rule out red flags such as weight loss. Maybe also blood on the hard stool could be a red flag. And then we need to inquire into the stool consistency, the frequency, and of course, how hard it is to get out. And then we consider serious causes, such as, is there the possibility of a spinal cord injury, a malignancy? And there, people very often complain about constipation, followed by diarrhea, which affects the right colon more than the left colon. And then we were looking at possibilities of anatomic obstruction, which was the case in our patient, such as strictures secondary to radiation or a mass in the colon. Then we were looking at gradual changes in the motility, and these could be related to dietary changes, so, as well as to medications such as laxatives that are very often abused by patients who suffer from constipation. These are bisubcodal and to a certain extent senna. These cause electrolyte disturbances, I think loss of potassium that can cause even further constipation. And then we have medications like opioids, iron supplements, and calcium, which can cause constipation, as well as endocrine influences like hypothyroidism. Then an MRI and CT and later an ultrasound showed that there was an ulcer in the sigmoid colon. So we had most likely an anatomical obstruction, and the ulcer could be secondary to inflammatory diseases like IBD, Crohn's disease would be one of the possibilities. Radiation, which the patient received, but a long time ago, so why 23 years later? And then infection like tuberculosis and C. difficile can cause ulcers in the colon. As it showed, the biopsy revealed a squamous cell carcinoma, which originated from the vagina, and it eventually, over the year of 23 years, spread to the sigmoid rectum. And an interesting teaching point from Zaven that our vaccination for HPV can avoid these complications for our young people, but I think also for the elderly. Thank you very much. That was for this great case.
Thanks, Hans, for the outstanding recap, Ravi. Well, what a great case to learn from. Thank you. And thanks, Magnus, and everybody for joining. Have a great rest of your day.
Thanks, everyone. Take care.